Hello everyone and welcome to today's webinar on vertigo and balance disorders. For those of you just joining us, welcome. We will start in a few minutes. Request all of you to please mute your microphones. Global Pharma is a pharmaceutical company run by doctors with strong ties to Myanmar. We at Global Pharma take it as our privilege to promote the collaboration and sharing of knowledge between medical professionals in India and Myanmar. At Global Pharma, we pride ourselves on keeping updated with the latest research and advances in the field of medicine and sharing this knowledge with doctors across the world in many ways, including a monthly Health Digest journal and regular webinars. I would now like to introduce our first speaker, Dr. Anita Bandari. Dr. Bandari is a neuro-otologist and ENT surgeon who was trained in India and Singapore. She is a trailblazer in the development of diagnostic equipment in the field of vertigo and balance disorders and has 3 patents in this field. Dr. Bandari has authored chapters in several neuro-otology textbooks which are widely acclaimed and has spoken at vertigo and neurology conferences worldwide. She is the scientific advisor to Neuroequilibrium, a groundbreaking project to set up 500 super specialized vertigo clinics globally. Welcome, Dr. Bandari, and thank you so much for doing this today. The chairperson for today's webinar is Professor Kinlala. She is a honorary professor at the University of Medicine in Yangon and president at the Neuro-Audiology Special Interest Group in Myanmar. She is extensively qualified with training experience in many countries and is a fellow of the International College of Surgeons and the American College of Surgeons. Welcome, Dr. Kinlala.
Hi.
Hi. Our second speaker is Dr. Yin Twe. She is an associate professor at the ENT department of the University of Medicine in Yangon. She will be speaking to us on the Myanmar perspectives of vertigo. So welcome to all the participants, and we thank very much all the speakers today, and thank you so much for coming today. Dr. Anita, the chairperson, Professor Kinlala, you can take over now.
Thank you. Thank you, Jimbao. We will welcome to all of the audience to the webinar on the practical approach to vertigo and balance disorder, international Myanmar approach. As you all know, vertigo is a condition where a person has a sensation of moving or of surrounding objects moving when they are not. And sometimes it is associated with nausea, vomiting, sweating, or difficulties walking. And regarding balance, it is controlled by eye, inner ear, and proprioception. Therefore, any pathologies involving these three can lead to balance disorder. Today's webinar will be emphasized on one, basic understanding of normal anatomy and physiology of equilibrium and how normal balance is maintained, and differences between the dizziness and vertigo, and the impacts of vertigo, and what are the types of vertigo and the causes of vertigo, and how to differentiate central and peripheral vertigo, and how to diagnose possible causes of vertigo like benign BPPV, and how to manage the causes of vertigo. And we are lucky in the sense that we will also have some case scenario. So today it is lucky that today we will have the two invited speakers, Dr. Anita and Dr. Yin Twe. And so we will have different aspects of vertigo in the sense of different countries in India or Myanmar. And it is no doubt about their experiences in field of neuro-otology. And I'm glad that as the president of Neuro-Otology Special Interest Group of Myanmar, I'd like to invite first speaker, Dr. Anita Bandari. Welcome, Dr. Bandari, for your presentation.
Thank you, ma'am. Thank you for that kind introduction. I'd just like to share my screen now to start the presentation. So thank you so much for the invite today, and thank you Global Pharma and Especially we have such an esteemed chairperson with us, Professor Kinlala, and my fellow speaker, Dr. Yin Yan Wei. So today I'd like to talk about a practical approach to vertigo and how differential diagnosis is required to give correct treatment to our patients of vertigo and imbalance. So when a patient comes to us, the first thing is most important is history. But history can give us a variable picture. So you can have different kinds of complaints from the patient. The patient can be dizzy along with unsteadiness. And that is when we think, is it vestibular or perhaps is it a cerebral disorder? If a patient complains of positional vertigo, the first diagnosis that springs to mind is BPPV. But we also need to remember that vestibular migraine, peripheral vestibulopathies, and even in some cases, central positional nystagmus can also present with positional vertigo. And if on clinical examination we see spontaneous nystagmus, we will need to differentiate whether this is vestibular or something more sinister in the central nervous system. So I'd like to just say one sentence: vertigo is not a spot diagnosis. We need to do a detailed history, clinical examination, and evaluation to find out the real causes. And the first matter of concern for us is it peripheral or central? Because finding out a central disorder at the earliest could mean the difference between life and death. And if it is a peripheral disorder, although it is more benign in character, we still need to find out the cause to give a correct treatment to this patient. Life-threatening disorders can masquerade and present in similar presentations as benign peripheral disorders. So it will help us to find out or diagnose that this is a peripheral vestibular disease rather than a central one by doing this is what I'll be talking about today. So from the history and clinical examination, we get a lot of clues. But to make sense of all of those clues, we need to do a vestibular assessment to make sense of all this and complete the puzzle. A lot of us are ENTs in this webinar, and I'd like it's very easy as an ENT person to understand that just one look at an audiogram and immediately you start thinking of diagnosis and treatments. So just the first one, if I talk about SN loss, moderately severe, you think about, okay, this patient would require a hearing aid. The second one, a conductive hearing loss, probably is this CSOM? Does this patient require tympanoplasty? And if I talk about the last audiogram, immediately you think, okay, maybe this patient will require a cochlear implant. So similarly, we need to evaluate each part of the vestibular system. The vestibulo-ocular reflex, vestibulospinal reflex, the otoliths, and all their central connections are evaluated by various tests, which I'll be talking about. And by doing these tests, we will be able to form what we call a vestibulogram. So, testing the vestibulo-ocular reflex at different frequencies. So, just like audiogram is not tested at one frequency, you need the low, medium, high frequencies to really get a clear picture. Similarly, the vestibular system also works at various frequencies and different tests are required to understand. Along with the VOR, we also need to assess the otolith and the vestibulospinal system. So let me talk about the VOR first. Now, to look for spontaneous nystagmus, it is very important for us to block fixation because optic fixation reduces spontaneous nystagmus. We can do this clinically in the outdoor in various ways, like keeping a blank sheet of paper in front of the patient's eyes and looking for nystagmus from the side. Or you can throw a bright light into one of the eyes and look for nystagmus in the other eye. But a more precise method of doing all of these eye recordings is the video nystagmography, or what we call the VNG. And this involves electronic scanning using infrared cameras of the eye movements in various oculomotor and vestibular tests. These are the various kinds of tests we do to understand the oculomotor and vestibular system in different conditions and look for induced nystagmus. So I'd like to talk about some clinical cases to make it more clear. So this was an ICU resident, 27-year-old lady who came to me with acute vertigo since the last few days, accompanied with nausea and vomiting. So here you can see that this patient has a spontaneous right beating nystagmus. And after about 20 seconds, a light goes on and the patient is asked to look at it. Here you can see now with optic fixation, the nystagmus has subsided. So reduction of nystagmus amplitude is a clear sign of peripheral vestibulopathy. We treated this patient as a vestibular neuritis case, gave her high dose steroids, and she responded very well. Now, this was another patient. He is actually a doctor's father. So the doctor called me and said that my father has acute spinning since the last 2 days. He is not able to get out of bed. Please give me some medicine and I'll bring him to you after a few days. So I said, no, you need to bring him down. We need to evaluate and just see what the findings were. This patient had vertical upbeating nystagmus. We immediately, so this is a sinister sign. Vertical nystagmus on VNG is a sinister and the sign of something more dangerous. And when we went for imaging, it turned out that the patient had a cerebellar stroke. So needed immediately ICU treatment. And fortunately, he did well after the treatment. Now, this was a, sorry. I can keep speaking. Just a sec. I think there's some, the video has got hung. So this was a 35-year-old young dentist who came to me who said that when he would bend down to see his patients, he would have a slight unsteadiness. He was also complaining of tinnitus in one ear. When we took him for testing, it turned out that he had a unilateral hearing loss. I just like to, so there's some hitch in the video. So there was, just a second, I'll just share, I'm just stopping the share and joining again, just 1 second.
I think we have over 179 participants and more coming in. We just are looking forward to the rest of the presentation as we go along.
Right, just a second. So this patient actually, it turned out that he had direction changing nystagmus. And we took this patient for imaging and it turned out, so here you can see the video playing now. So right now there is right beating nystagmus and in between you'll see that sometimes it starts up beating as well. And when we took this patient for imaging, it turned out that he had a large acoustic neuroma. So he required surgery, and so that slight fleeting imbalance turned out to be something quite sinister. And he actually had been to quite a few doctors, but it was not diagnosed until we could actually do this VNG. Just 1 second. I'm just sorry, getting. Uh, so now this was another 65-year-old female who had come with facial pains, headaches, intermittent unsteadiness, and the patient had tinnitus. And when we took the patient for an evaluation, it turned out that she had hyperventilation induced nystagmus. So here you can see the hyperventilation in which the patient is asked to hyperventilate, breathe deeply in and out for about 30 seconds. And it turned out that the nystagmus was there. We went for imaging and it turned out that there was a vascular loop compressing the 7th and 8th nerve. This is what we call vestibular paroxysmia. These were various cases which I showed how vertigo and imbalanced patients can be evaluated and differential diagnosis can be achieved by the VNG. And the next thing I'd like to just talk about is one of the most important conditions and most common conditions causing vertigo is BPPV. So, sorry, just 1 second. Just go to the next one. So, vertigo caused by BPPV is usually because of the otolith from the utricle coming into the semicircular canals and causing the patient to have vertigo on change of position. Now, according to the position of the otolith, it can be in each of the canals, the posterior, the horizontal, or the anterior. But even within each canal, if it is in the long arm, the short arm, or different positions, we will get different kinds of nystagmus. It has now been said that there are 14 variants of BPPV, and according to where that crystal is within the semicircular canal, whether canalolithiasis or cupulolithiasis, and in which canal, we would need to decide which would be the best maneuver to treat the patient and bring that crystal back into the utricle. So this is a table from my book, which I recently wrote about BPPV. It's an e-book, which I'll just share about it later on. So even in the posterior canal, there can be 5 possible positions of the otolith. And according to the position, we have to decide which maneuver would be best. So you can see that each position, whether the long arm or cupulolithiasis or the short arm, each one of them requires a different kind of maneuver to get the best results. So if I go to the VNG of a posterior canal long arm BPPV, the first video which you'll see playing, after a latent period, we get torsional upbeat nystagmus, which is very clearly seen both on the video and the graphs. Here we see upbeat nystagmus along with torsion. And when the patient is asked to sit up, there is a reversal of this nystagmus. So this is a long arm posterior canal BPPV. But if I play the second case, the second video, with upbeat nystagmus after the reversal of nystagmus, which you could see for the posterior canal BPPV. And now I'd like to show you another video in which this patient, when taken to the Dix-Hallpike position, it turned out that there was downbeat nystagmus. So not the torsional nystagmus which you see in posterior canal long arm, but rather this was a downbeat nystagmus. And this indicated that the otolith was in the crus commune or in the non-ampullary arm of the posterior canal. So differentiation between both of these positions is very, very important because this will help us decide what kind of maneuver we need to treat the patient. So I just like to show you a simulation of the Epley's maneuver in 3 dimensions so that you can understand how the otolith moves. So when the patient is taken to the Dix-Hallpike head hanging position, the otolith shown in the posterior canal is moving to the most dependent part of the canal. When the patient's head is turned to the opposite side by 90 degrees, you can see how the otolith moves further, and then finally in the nose pointing down position, the crystal will enter the crus commune to go back into the utricle. So this is how the maneuvers work. The Epley's maneuver is dependent on gravity to help the crystal be to gravitate towards the utricle for the patient to get better. Now, if the crystal is in the anterior canal or in the crus commune, it is the Jacobino maneuver which is required. Here you can see when the patient is taken to the deep head hanging position, how the otolith moves, and then patient's head is flexed by 30 degrees for it to move further within the canal. Finally, the patient is brought back to the sitting position and the crystal moves from the crus commune back into the utricle. So it's important to wait at each step during the maneuver to allow sufficient time for the crystal to move within the canal and reach the most dependent position. So you can see the yellow ball depicted as the crystal coming back. Now, when we talk about horizontal canal BPPV, which is tested by the supine head roll, then we see that the nystagmus in this case is horizontal, and it can be beat either towards the ground, what we call geotropic nystagmus, or away from the ground called epigeotropic nystagmus. So in this case, here the viewer will see that when in the right lateral position, there is a right beating nystagmus, while in the left lateral position, there is a left beating nystagmus. So that means this patient has direction changing geotropic nystagmus, which is seen in horizontal canal BPPV. Now here we need to differentiate and find out which is the stronger nystagmus to decide which is the affected canal. And from there we can do various maneuvers like the barbecue maneuver or the Gaffoni maneuver to bring that crystal back into the utricle. When we treat these patients, we should also be aware of atypical forms of nystagmus which we may see. So here you can see this was a 35-year-old male who came with severe spinning and vertigo along with nausea and vomiting. But when we took the patient to the different positional test, it was very strong nystagmus, which without any latent period, and it was not fatigable. Any position we would take the patient, there would be the strong upbeat nystagmus, the vertical nystagmus. So clearly, this is not a picture of BPPV, and we sent this patient to him, and it turned out to be CNS tuberculosis. He responded well to anti-tuberculosis. Now, another test I'd like to talk about is the dynamic visual acuity test, in which we compare the static visual acuity of the patient to the dynamic visual acuity. That means how the patient is able to focus during hand movement. This is a very sensitive test for the vestibulo-ocular reflex and helps is one of the fastest and simplest tests for vestibular toxicity and bilateral peripheral vestibulopathy. Another important test is the video head impulse test, in which again a test for the VOR, vestibulo-ocular reflex. The patient wears this sort of a goggle, and with a smooth, fast jerk, we have to find out if the patient has any catch-up stage. This is a test for all the 6 canals. So individually, you can test all 6 canals in this. Another is the subjective visual vertical test used for otolith disorders. It tests how the patient is able to uh, to using tubular goggles within a dark room, the patient is shown a vertical line, and they are asked to make this straight, both under static and dynamically moving backgrounds. And if this angulation is more than 3 degrees, it is considered to be an otolith dysfunction. So very simple tests, but they give us a lot of information. So by doing these various tests, we are able to differentially diagnose which condition it is. You have to combine it, of course, with a detailed history, clinical examination, but follow it up with vestibular evaluation. So suppose it was a Meniere's disease, we would be able to differentiate and treat it with dietary modifications, with you can say diuretics or beta histine. If it is a BPPV patient, we have just talked about how maneuvers will help these patients. Here, there is no need for any medical treatment. In patients of ototoxicity, which is very easily diagnosed with tests like calorics and with the dynamic visual acuity, we must immediately stop the drug which is causing the ototoxicity and put the patient on rehab, vestibular rehabilitation as soon as possible. Patients with vestibular migraine will require lifestyle modifications along with specific migraine prophylaxis. So, thus, you see, by giving a definitive diagnosis, we can also channelize it towards definitive treatment protocols. I'd like to talk a little bit about vestibular rehabilitation now, because a lot of our patients will require rehabilitation. And this is often the missing link, something which is left out in the management, because patients of peripheral vestibulopathies, unilateral, bilateral, vestibular neuritis, labyrinthitis, all of these patients will require rehabilitation to give a better outcome. So, if we progress from a structural evaluation, checking the VOR with various tests like the VHIT, the dynamic visual acuity, and VNG, testing the otolith system with the SVV, subjective visual vertical, checking the vestibulospinal system by different tests like uh, the computerized dynamic posturography, craniocorpography, and then the central inputs through the VNG, we will be able to really understand what is the structural deficit and then work on it to improve the functional, uh, the outcomes of these patients. So we are all aware of the Cawthorne-Cooksey exercises, which were actually proposed by Cawthorne in 1956. But our knowledge of the vestibular system has grown by leaps and bounds in this almost half a century. And now we realize just doing these exercises is not adequate. We now understand the system and are able to understand how to give more um different types of treatment to give better results, because vestibular rehabilitation, it is has been documented that 1/3 of all adults with vertigo require rehab, because these patients suffer from postural instability, visual blurring on movement, and they are at an increased risk of fall. And this requirement for rehab just increases exponentially with the patient getting older. So, by doing our balance testing, the vestibular evaluation, we are able to understand the deficit that the patient has. And according to that, we have to develop our compensatory strategies. So, thus, you see that from generic rehab, giving only Cawthorne Cooksey exercises, we are now moving to tailor made, customized rehab, which needs to be progressive. You cannot just keep doing the same exercise and expect the patient to be better and improve. So now it is well established that rehab protocols must be site targeted according to the deficit within the vestibular system. The exercises have to be progressive, starting with low intensity and gradually increase in the challenges given to the patient. And constantly, this factor is very, very important, giving an incremental error. We have to challenge the system and give an error for the patient to develop a compensatory strategy to that sensory mismatch which it detects. By giving same exercises, if no error is detected within the central nervous system, the patient will not compensate further. So let me talk about various parts of the vestibular system. So when we talk about semicircular canal dysfunction, that means an angular VOR dysfunction. Here we have to work on visual cues, increase the head movement, never go for things like head restriction, cervical collars. We need to potentiate all of these movements to give better results. If the patient has vestibulospinal function dysfunction, then we work on alternate stabilization strategies using ankle and hip movements in different ways and giving dynamic conditions to challenge the sensory system. If the patient has an otolith dysfunction, that means usually these patients do not really complain of spinning or vertigo, but rather they feel a swaying, an unsteadiness, a feeling of rocking. That is when we have to give linear accelerations. So, like exercise ball, working with different surfaces, trampolines, etc. And also, when we go for our treatment, we need to monitor the progress of our patients. So, this can be done by tests like the craniocorpography. So, if you see the first graphs here, you can see on the Unterberger test, we did the CCG and saw that the patient went almost 150 degrees spin. But with the rehab, the patient has progressed and has become much more steady with all the parameters coming within the normal limits. Similarly, dynamic visual acuity is a very good functional tool of how the patient is able to keep the eyes steady during head movements. And here you can see a progression with rehab after for a patient of peripheral vestibulopathy. So we are also giving our patients rehab through certain apps in which every 10 to 20 days we change the exercises so that they constantly have new sets, more challenges, which gives better outcomes to our patients. And this is a question I'm often asked is during these COVID times, can we still do the test? So just a short video to show how these patients at my own clinic, how we are using aseptic and hygienic precautions to make sure that it is safe both for our patients and for our staff. So sanitization of the medical equipment before each test. We are using disposable foam covers on our VNG and changing all the sheets and everything before and after each patient. So yes, we can do all the tests in a safe environment and so I just like to end my talk with this very important thing that we need to understand our patients' needs. And one kind of treatment, one rehab, one maneuver does not work. We have to fit our treatment plans according to the requirements of our patients to give the best outcome and best recovery. I just like to end. Thank you all for your attention, and just like to end with this is the book which I've just released. It's an ebook on BPPV, which talks about all the variants of BPPV, how to diagnose them, everything which is required for anyone who treats these patients, all the maneuvers, along with animations, simulations to give a clear understanding of the whole condition. So, thank you so much.
Thank you so much, Dr. Anita. This is a very well done speech. Thank you so much. And we are very happy, and I'm sure it's very useful to the doctors and to the PG students, your talk. Now I'd like to hand over the platform to Dr. Yin Tue. Dr. Yin Tue, you can take over for your talk now.
So I would like to invite Dr. Yin Tue for next presentation.
Hello, good afternoon to you all. First of all, I'd like to thank to the Global Pharma for inviting me to give this webinar, and thanks to my chair, Prof. Kelala, for your kind introduction. Also, you are my mentor in our neuro-audiology field. I'm honored and humbled for giving me the chance to share our perspectives on the Vertigo to the local and the international colleagues. Why Vertigo is a concern to both the patients and doctors. It is one of the most reasons of absences from the daily work. Understanding causes should be ranging from the benign, not serious, to life-threatening fatality conditions. Attending physicians usually have missing of the serious pathology, and actually, Vertigo is nobody's baby. Sometimes ends in the general medicine clinic, and sometimes in the neuro clinic, and sometimes ends in the oral HNS clinic. Even myself had a Vertigo since I am in a doctorate student life. When I woke up in the morning, suddenly felt very busy and everything around me was spinning and provoked by the head, right position, and unable to stand and walk. All I couldn't then by myself also had severe nausea and vomiting. It is a typical presentation of the PPPB, but likely relieved by the medical treatment and rest only. Even less than about a week, I will never forget this experience in my life. So the Vertigo is very challenging to our life. So here, these are the topics I go through for the next 30 minutes. I will show some of the presentations, the PowerPoints, overlaps of the Dr. Anita presentations, she already present very comprehensively and very informatively that uh, these are some are the important facts. So I will show again. So please bear with me. Just to fresh, I will talk briefly on the physiology of the SEM, physiology and how do we maintain normal balance, and then how we differentiate the peripheral and the central vertigo, and then we have the diagnosis and the management of the acute episodic vertigo. What are the simple ways of diagnosis? What are the useful diagnostic maneuvers and effective particle repositioning maneuvers? What is the treatment of the common peripheral vertigo? And lastly, I will conclude my presentation with some interesting case scenario in our hospital. So to be able to maintain our balance, our balance normal life, and things around the pathways of the process have to be good condition. The effects can be from the visual in the eye, vestibular in the ear, inner ear, and the somatosensory receptors for the proprioception, field in the joint, and these effects import to the brain, in which these imports are integrated. After the central integration, the inputs goes to the end organs and then finally able to stand with normal posture and able to walk with the normal gait and able to coordinate with the head and eye and able to see clearly. That's why we can fix the target. So in generally, the vestibular system consists mainly of the 10 sensory organs, 5 on each side. On the right left brain, there is a lateral semicircular canal, and the lateral or the horizontal semicircular canal, and the interior or the superior semicircular canal, posterior or the inferior semicircular canal, and the utricle and sulci. So the other side is also have 5 organs, sensory organs. The first pathway, there are the two pathways, mainly two pathways. The first pathway is the vestibulo-ocular reflex, contribute to the ocular stability and when the head is in position of motion. The second pathway, termed the VSP. VSP is the vestibulospinal pathway. It's used to produce the contraction of the muscles for maintenance of equilibrium during movement as well as have maintained musculature. This is the musculature during the along the proprioceptive joints. Here, the picture shows the inner ear, which contains the 3 semicircular canals, the superior, lateral, and the interior and the posterior, and which ones responsible for the sensory angular acceleration, and 2 autolytic organs, utricle and the saccule in the middle, which ones are responsible for the linear acceleration, either to and fro, up and down, and side by side movements. These are connected to the vestibular nerve, either superior or inferior vestibular nerve, and then goes to the central connection. This is the superior vestibular nerve, which contains fibers from the horizontal semicircular canal, anterior, utricle, and part of the saccule. And also the inferior vestibular nerve contains fibers from the posterior semicircular canal, majority of the saccule. And so this cartoon shows the vascular treat of the balance organ and the hearing organ. Vascular supply of the vestibular organ is connected with the vestibular supply of the cochlea. 45% comes from the anterior inferior cerebellar artery, and so the vasopressin, that is the ischemia or infarct due to the lower perfusion or the hypotension, can cause concomitant vertigo and hearing in the organic cause of the vertigo. And this is the semicircular canal, which plays an integral part of the balance system. Posterior canal and interior canal shares the plane with the controller with the offline from the 45 degree, and horizontal is the 30 degree, and horizontal canal shares the plane. And these semicircular canals are stimulated by the angular acceleration, and it is greatest when fulcrum is within head, and it induces relative motion of the endolimb, and crystal is displaced by the fluid motion. This is the autolithid organs, utricle and the circle. Circle is a roughly vertical orientation, responds to the acceleration components within the sagittal plane. Utricle, horizontal plane, and 30-degree orientation. Yeah. Yeah. This is the vestibular nuclei of the two pathways, vestibulo-ocular pathways and the vestibulospinal pathways. So after knowing of the anatomy and the physiology, I'm going to tell about how to differentiate the central and the peripheral or the vestibular or the non-vertiginous, non-vestibular causes of the dizziness by general assessment. Of if we take this assessment in timely in the right way in an acute setting, the patients will save the life and get prompt treatment. A thorough history taking and physical examination to exclude non-vestibular causes. For example, it could be due to the cardiovascular causes in any hyper or hypotension, any dyspnea, any arrhythmia, and previous myocardial infarct or ischemic heart disease, especially in the elderly patient. If there is any stroke, any Einstein diplopia, or other cranial nerve palsies with the neurology deficits, and it could be due to the neurological causes. It is important to recognize condition requiring urgent treatment. That is the ischemic heart disease and cerebrovascular accident disease. These are the points not to be missed when we assess the patients with vertigo. In our hospital, blood tests and other additional workups are not usually done in the first visit, and if we suspect the non-vestibular causes, we make the timely accordingly. This slide is so many feeling to describe the various forms of the dizziness. It is important to differentiate the nature of the present symptom. True vertigo or syncope and pre-syncope or any other forms of the dizziness. Actually, from the history, the most integral part is to make sure that it is true vertigo. So now let's see the video of the vertigo. Yeah, vertigo is is an illusion, not a diagnosis. A feeling of spinning of the own body or our environment. Patients usually describe in their own words, so we need to interpret their complaint correctly. So let's see the video, and you already see, and this is our hospital building. By seeing this entrance, from the entrance, and we can ask the patient whether did he feel like this or not. The patient says yes, it is true vertigo. And we will go to the another test. But this video, the video, yes, this video, the building was including the signboards are moving up and down, and this may be the oscillopsia due to the visual problem, and sometimes the objects are moving like this up and down and side by side, also the particular direction in the same attack. It can be due to the disequilibrium. This video is a gradual fainting or the blackout. This is due to the syncope or the pre-syncope. So once vertigo is confirmed as a true vertigo, we need to ask patient in detail regarding the symptoms. It is the constant or episodic. If episodic, what was the duration and frequency of the attacks? What are the triggering points and how did it begin, gradual or sudden? What are the aggravating symptoms and alleviating factors? What are the accompanying symptoms? Where I would like to say one key point, any type of the dizziness may worsen with the position change. But some disorder, such as the benign paroxysmal positional vertigo, can only occur after position change. We also need to get information uh, about the hearing assessment, hearing present or not, and how long it with it. These are the pinpoint to get the diagnosis. This algorithm is the simple way of the getting diagnosis of the patients coming with the vertigo. It's useful for the three most common causes and one central causes: mania disease, BBPV, acoustic neuroma, and then vestibular neuronitis. If there is a hearing loss and vertigo is intermittent, it is likely to be the Meniere's disease. If hearing loss with the persistent vertigo, it can be due to acoustic neuroma. If without hearing loss, vertigo is intermittent, it is usually due to the PPPV. It will be vestibular neuronitis if vertigo is persistent without the hearing loss. So this show again how to differentiate the vestibular or the psychogenic. If it lasts minutes or hours, it is likely due to the vestibular cause. It usually worsens with the head movement and also associated with the ataxia and balance. If symptoms are reproduced by the hyperventilation test and hyperventilation positive test, it's likely to be psychogenic. Whether in the psychogenic vertigo, usually it is very transient. Ataxia is absent and flash all the time. Duration is flash all the time. This shows how to differentiate peripheral and the central causes as we already know well-known tables, so I will not go through in detail. This shows how to differentiate according to the nystagmus. In central nystagmus, there is a no latency, no fatigability, and direction can be variable. It is reproducibility. In peripheral nystagmus, there is a latent period and fatigability and usually and unidirectional. Latency means the time period between the attaining head position and onset of vertigo or nystagmus. Fatigue means the disappearance of the symptoms over the maintenance head position, and reproducibility means the likelihood of the symptoms producing protection during any examination. And in recurrent vertigo, we need to rule out of the following. It is positional, it is due to the PPPP, it is paroxysmal. Paroxysmal is the episodic, means so it can be due to the vestibular paroxysmal. And if there is a hearing disorders and Meniere's disease, if there is a loud sounds, Junio phenomenon, if there is a triggering factors and migraine, and ataxia, episodic ataxia, and the brainstem if there is a brainstem symptoms, TIA, and and so on. So if this is not uncommon to have vertigo as a chronic condition, and it may be due to the failure of the compensation of the fluctuating vestibular lesions, visual dependence, and psychological factors, excessive bed rest or lack of physical activity, excessive use of the psychotropic and antipartigenous drugs, and concomitant visual of the neurological disorders. So when the vertigo patients comes to our hospital, most of them are referred from the general physician and some are from the neurologist and some are others. This is what we do in tertiary care center. At first, thorough history taking and physical examination done for each and every patient. Ear examination also done with the otoscopically and the microscopically, and purine audiogram also done. It is the most useful test which can available in all district hospital in our country. In Meniere's disease, it is not only for the monitoring of the severe hearing, but also for the pitch or the level of the tinnitus, how to cover or not, we all can know. We do other tests such as the impedance, audiogram, and OAE as and when necessary. Then after PTA, I'm going to talk about the vestibular test, in which vestibular nystagmus can be seen. The spontaneous nystagmus have either a peripheral or central pattern. Peripheral pattern of the spontaneous nystagmus is unidirectional. So this the clinical vestibular test, which is doing with or without video or with or without machine. And these all tests are routinely done in all vertigo patients who are not really find the symptomatic treatment. The first one is the VNT. Video nystagmogram is very useful in videos in vertigo setting. It is test battery, includes saccades, case test, smooth tracking OPK test, which are altogether called the oculomotor test, and also includes the positioner test. This is called the Dix-Hopper test and bithermal chloride test. The other possible tests in which VOR, hyperventilation tests, and head shake tests are involved. But these tests are not routinely done. It is particularized and prioritized in each special case. It has to be done in a few category of the patients. The second one is the VHIT. The second one is the VHIT. If the patient comes to your emergency with an acute vestibular symptom, such as the unable to stand, unable to lie down to one side with a spontaneous nystagmus, what we can do is one-stop solution. It is a VHIT to distinguish the central or the peripheral causes. The third one is the HINTS. It is very useful clinical vestibular test. It includes HI for the head impulse, and N stands for the nystagmus, and TS stands for the test screw. There are some additional tips or hints. Hints infarct. Hints infarct is a head impulse and fast phase alteration, that is the bidirectional nystagmus. The eye moves to the refixate during the cover dress, is a T. Hint plus also contains the hint plus PDA. It is for the hearing. These tests are very useful for the vertigo to differentiate the central and the peripheral vertigo. Yeah, there is the test we usually do during the follow-up. I will not go through in details of the test as it is already mentioned in the earlier talk, very comprehensive talk. So we will not go to that in detail. Rampage tests and the end-of-winter tests are very useful in bedside clinical setting. Rampage tests on proprioception or the vestibular test on the proprioception or the vestibular functions. It can also be positive in the neuromuscular disorders and may not be reliable in every elderly patient. Arthroventure test is to identify damage to one of the labyrinths to know the vestibular pathology and not useful for detecting the central disorder of the balance. Hyperventilation test for 60 seconds may help in ruling out the psychogenic causes in lingering patients. Two, it is can exacerbate vertigo. It is very bad. It can exacerbate a perilymphatic fistula or acoustic neuroma. So not already done this test. After taking off the workflow of our vertigo setting, we go to the interesting some case scenarios. First case is the 50 years old male presented with the fifth day of the vertigo associated with the nausea, vomiting, and with the normal hearing. And on examination, he had the nystagmus on the Dix-Hopper test. The Dix-Hopper test is already mentioned in the earlier talk, and it is very helpful test. BBBV is at 83%, and positive predictive value is at 83%, negative is at 52% in diagnostic area. And density of the induced sign symptom and should decrease in each maneuver if peripheral or central. Combination of the Dix-Hopper test and the nausea history of the vertigo and nausea and vomiting strongly suggests the peripheral cause. It provokes the pure vertigo or rotational or the torsional will without the latent period, such as the central. This is the oversaccade on the V-head. This also directs towards the diagnosis of the right posterior semicircular canal. This is the video of showing the downbeating nystagmus, which is typical for the BBBV. It is a typical trajectory beating upward and torsionally, with the upper pole of the eyes beating towards the ground. This is the VNG report, and the two paper on the right side show the patient proforma chart for patient proforma sheet for the Vertigo patient. This is the second case. The 43-year-old male presented with the 10 days of the onset, and Vertigo is very severe and also associated with the nausea and vomiting, and associated with the severe hearing loss bilaterally. Reduced bilateral caloric test is present. This is the we had also reduced gain on the bilateral or both sides. So this is from history, 10-day duration, less the whole day, and hearing loss is present. PDA shows significant bilateral exhalation. Bilateral caloric response is reduced, shows bilateral vestibular weakness. VHIT also shows too much decreased gain and saccades. Finally, it can be confirmed as a labyrinthitis. And this is the third case, 64-year-old male coming with the hard of hearing is the first symptom, and the other is second is the tinnitus, and then for the hearing for the 1 year Vertigo. Let's for the 5 minutes. History of the cerebrovascular accident present on the right side. This shows normal gain and VHIT. We hit normal gain, and so we have to proceed with the further assessment. But patient didn't come due to the fear of transmission of the COVID transmission during her follow-up. This is the VNG. This is the VNG report with no significant result. This is the 47-year-old female. And 15-minute Vertigo, hearing loss, tinnitus is present. Caloric response is so weak response is seen at the left side of the graph. Red and blue spots almost linear and near the midline. Oversaccade and frigate is also normal. This is the VNG report, and some of the central causes are, I want to cover a bit more details, that it is not common in our hospital. From history, physical examination, investigation, and we go the surgical treatment. We need to also to do the imaging, and management is usually by surgery in the limited cases. This is the migrainous Vertigo. Migraine is a very common and usually presented with a migraine with or without aura. Triggering factors are hormonal changes in women, fluctuations in estrogen, such as before and during the menstrual period, pregnancy, and menopause, seen in triggering headache in many women. Drinks, stress, food condition, sensory stimuli, sleep changes, physical activity, weather changes, medication, all can cause the migrainous related Vertigo. It can be treated by the medical treatment. This is the common causes of the Vertigo. BBB is the most common peripheral cause. It was the first described by Bereni and Bereni. But for the time constraint, I will skip these slides for the time constraints for the questions and answer portion. So already present by the Dr. Anita. Thank you, Dr. Anita. This is the maneuver. And the refractory period of the BBB. And this is the Meniere's disease. These slides you want to get from, if you can, from the Global Pharma. So Meniere's disease treatment and vestibular neuronitis, acute labyrinthitis, cholesteatoma, and summary. This is in summary regarding the treatment of vertigo. General symptomatic treatment is usually for all patients. Specific treatment is given according to the causes of vertigo, either pharmacological, rehabilitation, or surgical. Supported treatments such as the vestibular rehabilitation to lessen the need for central sedation or vestibular suppressant drugs. Counseling and reassurance is also important in all steps of diagnosis, especially for patients with a chronic vertigo. With availability of the more advanced technology and the facility in our hospital these days, and our patients are getting more accurate and prompt treatment and then subsequent getting the better management. And close collaboration with others medical disciplines and is also required to reach the correct diagnosis and treatment while avoiding unnecessary laboratory examinations. And lastly, I want to appreciate from the audio metrics from our hospital and Dr. Timawen for the data and collections. And thank you so much to you all.
Thank you, Dr. Yentui, for your presentation, which is really beneficial for the audience. And in her presentation, she described how normal balance is maintained and how to differentiate with vertigo and dizziness, and how to diagnose acute episodic vertigo, and the simple way to diagnose vertigo, and the diagnostic maneuver, and the management of vertigo in some case scenario. So shall we move on to the next agenda, and shall I hand over to the MC for the next agenda?
Thank you, Professor Kinlala. I would like to introduce Mr. Rajneesh Bhandari, Managing Director of Neuro Equilibrium, which is the world's first chain of vertigo and balance disorder clinics and has over 100 super specialty clinics in India. Mr. Rajneesh, you can start your presentation now.
Thank you, Dr. Juma and Global Pharma for giving us this opportunity. I'll now share the presentation. So Neuroequilibrium is the world's first and the largest chain of vertigo, dizziness, and balance disorder clinics. And as you're aware, dizziness and balance disorders affect 15% of the population. And there are 40 distinct diseases of the inner ear and the brain which can cause these similar symptoms. So this is the kind of center that is there in US and Europe. So this is Boston's Children's Hospital, which is part of the Harvard Medical School. And places like Johns Hopkins and others have a complete vestibular lab. Many of these were talked about in the earlier two sessions. So we manufacture all these diagnostic equipment, the video nystagmography, subjective visual vertical, caloric irrigators, video head impulse test, dynamic visual acuity, the craniocorpography for Unterberger and Romberg's test. We even manufacture rotary chairs, etc. So and all our equipment is CE certified. We have more than 125 installations in India, including all the top hospitals in India. We also have our installation in Indian Space Research Organization. Uh, and we are now going global. So we have clinics in Cyprus, Bangladesh, and we are now starting to set up clinics across Europe. Uh, our equipment is all very compact. They do not require a very large space. What is most interesting and important is that because these tests are new and they have not been taught in MS and MD, because these have been developed in the last 10 years across Europe and US. So we provide differential diagnosis and interpretation of reports through our specialized panel of doctors, which includes Dr. Anita and the neurologist. That is the unique proposition that we have uh, to enable the remote diagnosis. We have a remote history taking module, which is all digital. So technicians or audiologists can take history on this diagnostic platform, which is all digital. And these are the kind of reports that come out from our equipment, and we then provide remote diagnosis and remote interpretation. We also have two apps which were shown by Dr. Anita. One is a mobile app for doctors so that they can see the reports and interpretation of their patients. And the other one is for the patients, where they can see the exercises that they have to do, the prescription that has been given to them. This is about neuroequilibrium, and we once again want to thank Dr. Juma and Global Pharma for providing us this opportunity. Thank you.
Thank you for your information. And shall we move to question and answer questions because the time is running out. So the first question is for Dr. Parnati. It is from Dr. Demawin, the one running the inside of the vestibular clinic. And among the the types of posterior canal BPPV, which one is the commonest and which subtype is difficult to treat? Dr. Banerjee.
Is this for me?
Yeah. So shall we repeat again?
Okay. No, I got the question. So posterior canal BPPV can be of 5 types. And the most common is the long arm, which is involved, and canalolithiasis of the long arm, which can be treated with the Epley's or the Simon's maneuver. The more difficult ones, although more uncommon, are things like cupulolithiasis or especially cupulolithiasis of the canal side, which is often more difficult to dislodge the crystal. And also sometimes these patients require several maneuvers to treat them.
Wow. And there is another one for you. Dr. Banari, in case of BPPV, if patients come back with recurrent attack of BPPV and not respond with Epley maneuver, what kind of treatment will you give?
So yes, that's a good question. That BPPV can be of different types. So first of all, be sure about which kind of BPPV variant the patient has. And once we diagnose that, the treatment will be better. So suppose it was a long arm BPPV and you've treated this patient with the Epley's maneuver. Still, after around 5 days, we repeat the test and see whether the BPPV has resolved. Is there still nystagmus or not? So sometimes these patients will require more than one maneuver. Other things which we must be aware of is that we at each follow up you should do all the provoking tests. So along with Dick's Holpike, we must also do the supine head roll and the deep head hanging position to make sure that this is not a multi-canal BPPV. And if there is more than one crystal, it has to be treated from all the positions. The third thing is that certain patients, even though you do not see nystagmus with the VNG on your positional test, but they still complain of dizziness. So, this can be due to various reasons, like patients of vestibular migraine can have position induced nystagmus, but this is not BPPV and hence it will not respond to any maneuver because you have to see the distinct nystagmus. So, if you see the nystagmus on the provoking test, you have to treat it with a maneuver. But if it is not seen, then we should think of other disorders which the patient may be having, like peripheral vestibulopathies, like vestibular migraine, and then treat accordingly.
Thank you. So another question is for Dr. Yin Trip. What is the most common type of vertigo in your hospital? In my hospital.
You have to unmute, Dr. Inintwe, you have to unmute.
Okay. The most common type in our hospital is a Meniere's disease. It is very different from other hospitals because we are the tertiary hospital and the other hospital is a benign positional paroxysmal vertigo is more common. But some of the BPPV are relieved by the symptomatic treatment or the some medical treatment. And after that, they don't need to come to our hospital. And in Meniere's disease, they want further management. They fear and some other central causes, and so they came to our hospital. And have we have done the vestibular test and then history taking. So we get the diagnosis of the Meniere's disease. So Meniere's disease is the most common. The second is the BPPV, and the third is the neuronitis or the labyrinthitis. Thank you for your question.
And another question is also for Dr. Yin Trip. Can we use beta histine in other type of vertigo apart from Meniere's disease? And how long can we give beta histine safely?
Yeah, beta histine as the antihistamine group, it involves in the antihistamine group. We can give all the peripheral vertigo, especially very effective in the Meniere's disease. And we can prescribe to the patients and on depending upon the symptoms, and it is very good. But the other drugs are also give to the peripheral drugs. In the PPPP, there no need the drugs and vestibular exercise like that. Apply maneuver or the modified apply maneuver is better. But acute episode of the vertigo, the patients take medical or symptomatic treatment to relieve their. How long? For the how long they can take? It is almost. It depends upon the effectiveness, and it almost at least for 1 week and almost 6 months. For the 24 milligram daily divided dose for almost 6 months. Yes, you can.
Yes, another question is for Dr. Benari. What is the best time to start vestibular exercise?
So, vestibular exercises are usually started as soon as possible according to the condition. So, if the patient has like an acute vestibular syndrome, which is seen in cases of vestibular neuritis or labyrinthitis, we would like to start as soon as as soon as possible, because this will help in developing compensation. So perhaps in the first few days when the patient has intense vertigo and nausea and vomiting, we would like to give some suppressant. But after 5 to 7 days, it's important to start these exercises slowly, and then gradually, as the patient becomes more stable, we go to higher level of exercises. Always starting with the simple eye exercises. Try to keep the patient in a well illuminated room and go for slow head movements initially. Right. Thank you for the question.
Yes, maybe this is the last question. Uh, it is for Dr. Ian Trip. What which is vertigo common in children, and what type of vertigo is common in children? Is it peripheral or central? Or how do you treat vertigo in children?
And vertigo is not so common in the pediatric population because the children are no no too much complaint, not too much complaint of the vertigo. They don't know the vertigo vocabulary, how to describe their feeling, and so not so common. But which types commons are the most commonest of the vertigo in pediatric population is the migrainous associated vertigo, and it is diagnosed. It can diagnose from the history and the physical examination, and it can really find the medical treatment, symptomatic medical treatment. The second most is the benign paroxysmal vertigo. But not related with the position change. And how we can treat the vertigo in the pediatric patient with a and uh, it is that particular patients we have to consider a special need special investigation and special medications in the particular case. It is more common in peripheral than the central lesions. That's for that's according to my experience in pediatric population. Thank you for your question.
Thank you. And this is a bonus question to Dr. Pereira. In your opinion, what's the most reliable audiological test to exclude Meniere's disease?
Uh, so, Meniere's disease is a triad of symptoms with episodic hearing loss, tinnitus, and vertigo. And in between, the patient often goes back to normal. So, when we talk about audiology, the pure tone audiometry itself is quite a good test to track the hearing loss of these patients. We often do the small increment sensitivity index, the CC test, to check for retrocochlear disturbances. And the ECOG is used to determine if the SP-AP pressure has changed. But I would also like to add vestibular evaluation, where in the acute stage, the patient will have nystagmus, spontaneous nystagmus beating towards the same side, because this is an irritable lesion. While um, in the inactive stage, when the patient has settled down, it goes to the paretic form, the paresis. That means there is a weakened nerve, and that you can check on the head shaking test, in which you will get nystagmus beating towards the opposite side. Another useful test is the caloric test. Again, during the irritative acute phase, the patient will have a hypercaloric response, while during the later on in the disease, further on, often you have a hypocaloric or a decreased response on caloric testing. Thank you.
So thank you all for your participation, active participation in many questions for the two audiences, and which is really beneficial for us. And as we have learned from today's webinar, vertigo is a common ENT problem which is caused by many conditions and pathologies, and it is important to identify the root cause of the vertigo so that effective therapy brings out the best patient care. In this context, it is important to understand the normal balance control system and the pathologies causing vertigo, and to diagnose a specific disease causing vertigo, such as BPPV, Meniere's disease, and so on and so forth, and to provide the best patient care. And with the advent of new technologies, management in specific disease are ever changing, and we have to keep up with it. And that's why CME programs are really essential or beneficial for us. And we would like to thank the Global Farmer and all the speakers and all the audience for your active participation. Thank you so much.
Thank you, Dr. Kirlala. The meeting is now concluded, and we thank all the participants and all the speakers. Thank you so much for coming today.
Thank you so much.
Thank you so much.
Thank you all in Myanmar for being here. Thank you so much.
Thank you. Thank you all.
Thank you.